with medicine, got very interested in medicine again. Suddenly it was fun. I was getting results with my patients, but then I kept running into challenges where, okay, I have these cool new tools. Now, how do I integrate the other tools in order to, as Dr. Halassa says, not to shooting in the dark, but to actually practice evidence-based medicine again. But the difference is that this is really more of a translational medicine where you have experience, you realize that there's a lot of studies and that there are there are pharmaceutical-like medications out there that they might not be FDA approved. They are actually they actually serve an important role, and to not utilize them really puts us at a disadvantage. So as long as the data supports it within a reasonable degree, with our experience, with the fact that we understand how it works, and there's maybe even studies that the pharmaceuticals did on maybe on something similar, improved, that worked, that something that is essentially the same thing, but maybe more natural, will also work. Okay, so this is the place where I'm coming from. And one of the challenges I've had is I get a lot of patients with complex pain disorders, or what I've now come to realize are complex pain syndromes, that these people have conditions that no matter what I do, they can't seem to get better, whether it's a severe form of restless leg syndrome, or it's a peripheral neuropathy with restless legs at the same time, with diabetes at the same time. And, maybe I get some effect with a regenerative therapy. And again, these are patients that know me well. We've got trust in this, actually a real doctor-patient relationship. Imagine that. And they want to try other alternatives, even if it means it would be considered experimental. And through doing my own personal research and pondering, okay, now this isn't just hearing about this from somebody and going, oh, great, I'll try this now. No. I've pondered, I've labored, I have searched the literature, I've reviewed literature on a regular basis. And then, you know what? All of a sudden, you turn over a stone and it's like, wow, pure gold. And this is what I think I have uncovered. So great article here, targeting the innate repair receptor to treat neuropathy. Okay, now I didn't know what this receptor was, by the way, before I started, studying it. So the innate repair receptor, and by the way, my style is to almost do it like journal club. So I'm almost reciting the most important points, word for word from the article, and then sort of elaborating, spicing it up, and deriving meaning from it. So that's my style. The innate repair receptor is a heteromer of the erythropoietin receptor. It's actually a beta common, a CD131 receptor, which simultaneously activates anti-inflammatory and tissue repair pathways. So erythropoietin, obviously that's what the kidneys produce to stimulate red cells. Well, apparently there is a heteromer is a receptor. It kind of has two legs, but it's two separate receptors, but it's really part of the same receptor, if that makes sense. Where one thing binds to it, but maybe something else binds to it and has a similar effect, but not exactly the same effect. And this will make more sense. Data suggests that after peripheral nerve injury, the innate repair receptor is upregulated in the spinal cord and modulates the neurogenic inflammatory response. Okay, so you get some sort of injury in the periphery, but it's upright, something's happening in the spinal cord. And this is great for osteopathy, by the way. The recently introduced selective innate repair receptor, I'm just going to keep saying it, innate repair receptor, just to drive it through our brains if we're not familiar with it. AR290 is an 11 amino acid peptide initially tested in animal models of neuropathy. So it's like almost like a piece of erythropoietin, or maybe a little fragment of, or maybe the part that activates the part of the receptor that we want. After sciatic nerve injury, ARA290 produced a rapid long-term relief of mechanical and cold allodynia in normal mice, but not in animals with a beta common receptor knockout phenotype. And I apologize for the, I guess the computer doesn't like to, use a beta sign. So, okay, so already like mechanical and cold allodynia. Allodynia, by the way, I've been doing a lot of work with Greek, Latin, Greek root meanings, because I realize it makes a lot more sense if you know what the root meaning means. Allo just means other. So it's like other pain. So it's just something different. Why would cold cause pain? Or maybe something that you touch something, it shouldn't be painful, but it is painful, just like somebody with complex pain disorder, right? In humans, ARA290 has been evaluated in patients with small fiber neuropathy associated with sarcoidosis or type 2 diabetes mellitus. Sarcoidosis, of course, is like an autoimmune disease that causes these granulomas all over the body, especially particularly in the dermis. So it affects the small fibers, the little nerves that are sensing things. In patients with sarcoidosis, ARA290 significantly improved neuropathic and autonomic symptoms, as well as quality of life, which was assessed by the small fiber neuropathy screening list questionnaire. Wow, I had never heard of anything that's worked. ARA290 treatment for 28 days initiated a regrowth of small nerve fibers in the cornea, not the epidermis. Now that may be because it was easier. The cornea has a very extremely dense area. Well, it has the nerve fiber density is very high in the cornea, and maybe easier to measure versus the epidermis. And that's according to the article. In patients with type 2 diabetes, the results were similar to those observed in patients with sarcoidosis, along with an improved metabolic profile. Why in the heck would that happen? Could it also have effect on the autonomic nervous system? It's reducing overall body inflammation, therefore insulin sensitivity is improving. Those are my thoughts. In both populations, ARA290 lacked significant adverse effects. Oh, great, no side effects. I mean, I read the studies, and the side effects were, what it looked like to me, if you asked anybody a bunch of questions, somebody will say, yeah, I've got a dry mouth and they just happen to have it or something. I didn't see anything that indicated any real side effect whatsoever. These experimental and clinical studies show that ARA290 effectively reprograms a pro-inflammatory tissue damaging milieu. I say milieu, some people say milieu, into one of a tissue healing and repair. So it's reprogramming. I like that. That gets me that gets me excited. All right, and one day I will figure out how to do a slideshow. Okay. Oh, actually, I'm learning. All right, so now we're just at the beginning. Although our knowledge of the pathophysiology of neuropathic pain has increased significantly over the last decades, it remains difficult to control the chronic pain condition, which affects many patients. And that is true. Neuropathic pain is observed in a large variety of disorders that vary from metabolic and infectious disorders, which affect the small afferent sensory nerve fibers, diabetes mellitus, sarcoidosis, leprosy, not something I've ever seen, but to diseases of the central nervous system, stroke, multiple sclerosis, traumatic brain, spinal cord injuries. I see a lot of neuropathic type syndromes that are the result of all kinds of things. I even have a guy with, he's probably had 300 kidney stones or past 300 kidney stones in the past 30 years. Now, I don't know that figure accurately 100%, but it's a lot. And he now has, allodynia of his scrotal sac, and he has to stand up. He can't sit. I mean, he is a total mess. Which kind of makes sense, as we go through this. Patients with neuropathic pain share a spectrum of clinical symptoms, irrespective of underlying disease, including spontaneous burning, electrical pain, allodynia, like I said, the other kind of pain where it shouldn't hurt that much, and hyperalgesia, which is more of a noxious stimuli, like maybe a chemical sensitivity or something of that sort. Although multiple therapeutic options are available, only a minority of patients, this is in the regular world, 30 to 50% may achieve moderate to adequate pain relief with an average reduction in pain score of only 30 to 50%. Okay, so they're never ever well, and only a fraction of people get to the okay place with the current modalities. Well, the standard of care modalities, I should say. No disease modification treatment leading to nerve repair have been developed so far. Neuropathic inflammation. An important feature of neuropathic pain is the occurrence of peripheral or central inflammation. All right, so now we're getting somewhere. Okay, so you've got this thing, it hurts, and the hand hurts, but there's something going on the inside. Dr. Halasa actually did do a really good presentation on complex pain syndromes about 6 months ago, maybe a year ago, actually. No. Inflammation is thought to be caused by nerve damage and to maintain resulting painful symptoms, eventually resulting in peripheral or central sensitization with persistent allodynia or hypergesia. For example, there's ample evidence from animal studies that peripheral nerve injury triggers a spinal inflammatory response. So that the spine is having an inflammatory response from something on the periphery, with the release of nociceptive spinal neurons of pro-inflammatory molecules, such as fractalkine, chemokine, ligand 2, tumor necrosis factor alpha. And by the way, these are apparently these are, we use this lingo, but these are like find me messages, come find me, which results in the invasion of resident macrophages, which in the spinal cord are actually microglial cells. And then there could be monocytes from the peripheral blood towards the spinal cord level of the peripheral nerve lesion site. So it's actually attract the spinal cord. So you have this terrible injury, say, in your hand, and you've got a inflammatory response in your spinal cord at the same level. Yeah, that's all I got to say about that. I looked up NOC. I was curious about that one, by the way, to see what that means. Actually, I have it written down somewhere, but I can't remember exactly what it is. If it comes to me, I'll say it. Although the release of pro-inflammatory mediators from and NOC just means an offending, like it's somebody attacking. So an attacking, something is attacking the body, attacking the neurons, initiates a glial response. The activated microglia subsequently maintain and amplify the inflammatory response by the release of chemokines and cytokines. Interleukin is 1 beta, interleukin 6, TNF alpha. And from my understanding of immune system polarization, that would be a polarization towards Th17, which is something that we talk a lot about. You know, it's also the same, seems to be a commonality with autoimmune disorders. Could it be related to multiple sclerosis? Yes, I've read on that, and maybe even Lou Gehrig's disease. A lot of the autoimmune diseases, it seems like they all have this Th17, including COVID. So this, and possibly cancer. Well, it is associated. The inflammatory response is not restricted to the level of the nerve injury, but also moves in a cranial and caudal direction with concomitant symptoms of spreading mechanical allodynia, other pain. So essentially, okay, so now multiple levels of the spinal cord are inflamed and involved. And I don't think I put it in there, but I also think it also said in this article, there is also there can be a lateral spread, which means, is it possible if it's, say, if it's in the lumbar region, that could go in, the inflammation could go up or down and then out, and maybe now be a trigger for like colitis. That's where things get really interesting for me, okay? Because actually there was an article that ARA 290 actually has a very powerful effect on ulcerative colitis. So, but it's not this article. Although the neuroinflammatory response may eventually subside, neuroplastic changes occur in pain sensory and modulatory networks, which cause the persistence of symptoms. Okay, neuroplastic changes in pain sensory and modulatory networks causing a persistence. All right. An important feature of, did it go to the innate inflammatory response? Tissue injury caused by the pathogen invasion, ischemia, traumatic injury, or peripheral nerve damage activates an innate immune system response, innate being macrophage or monocyte, with attraction of macrophages and pro-inflammatory cytokines, TNF alpha, which are aimed at isolation and destruction of toxins, pathogens, and damaged tissue. Now, this is where I could just read this and it could just go through one ear and out the other, or it could be a major epiphany, as it was for me. To balance this destructive process, dampen the inflammatory process, and counteract collateral damage, apoptosis nearby non-affected cells, anti-inflammatory molecules are upregulated in response to the tissue injury, one of the most important ones being EPO, erythropoietin. The local synthesis and release of erythropoietin after tissue injury is distinct from its endocrine effect on the hematopoietic system, which is related to the release of low concentrations of EPO by the kidney. Basically, the EPO has a very fast. It's it's a lower amount, but it has a fast the half-life is very short. Go ahead. Hello. Okay. If you have questions, go ahead along the way. In contrast, the paracrine, autocrine, EPO-induced tissue protective effects are mediated through the activation of the innate repair receptor, which is a member of the cytokine 1 cytokine receptor family. The innate receptor repair receptor is a heteromeric receptor, because it basically has two sort of parts that comprises beta common, CD131, and EPO receptor subunits. The innate receptor, repair receptor, is typically not expressed by normal tissues, but rather locally upregulated in response to tissue nerve injury, hypoxia, or metabolic stress. Because the affinity of EPO for the receptor is low, high local concentrations of EPO are required at the site of injury. The affinity is low. Okay, so I said that wrong. It's not that there's a low amount of EPO there's a high local concentration required to affect that. So there has to be enough injury. So that actually speaks to me. So what if we're getting these low levels of injury that are not enough to stimulate enough local erythropoietin to activate those innate repair mechanisms, and then you have these neuroplastic changes, and you have a sort of persisting activated microglial response causing chronic inflammation and neuroplastic changes in the spinal cord. So nothing you do on the outside seems to work. And then they have pain far out of proportion as to what you would expect, and you can't see anything. And then it seems like there's something wrong. It's like it's in their head, which I'm sure there's been a few patients over in this world that have had that experience. And so you don't have if you've got the yin, but you don't have the yang. And so if there's an innate immune response, well, that's the yin. Then the yang, the counterbalance it, is the innate repair receptor. But there's not enough of it's a subtle injury enough that there's not enough EPO to turn it on, and now you're stuck. Now you're polarized forever. A number of studies confirmed the tissue protective role of exogenously administered EPO in experimental models of renal, cardiac, retinal, and neural damage. Wow, retinal? Okay, so anybody who's got retinal degeneration, neural damage, I mean, it's a lot of that. Renal, cardiac, post-heart attack, and this helps. Okay, so this is where it gets, okay, so let's humble ourselves. Clinical studies indicate that the use of recombinant EPO is associated with serious side effects such as arterial, venous thrombosis, hypertension, stroke, and it could cause myocardial infarction. If you just used EPO, like used it as, oh, okay, I just had some damage. Let me just give myself a bolus of EPO. Lance Armstrong apparently won 5 Tour de France's, and then had it taken away because he was using EPO and growth hormone, which I don't have a problem with growth hormone. to optimize it, maybe not, going crazy with it, but optimal is fine. I mean, this is a serious race, and you're breaking down and you're optimizing your ability to build yourself back up. Well, the idea, it seemed like when I read the articles, the regular people articles, that it's like all about, oh, okay, you took EPO to increase the amount of oxygen delivery because erythropoietin stimulates red blood cells. Oh, I get it. So then he's oxygenating. Yeah, he is a cheater. But interesting enough, it's almost as if he was breaking himself down, but he was able to repair himself with the epogen. And I think he took a diuretic, and that's what allowed him to not build up or to, have the hypertension, and maybe did something else to buffer against, stroke and blood clots. But still, I personally don't, it doesn't sound like it's safe to just use by itself, although it sounds amazing. So the use of exogenous EPO has not been pursued seriously in clinical studies requiring extended dosing. Only in people with kidney disease that there is drugs approved. Now, this is great because there's a bazillion, okay? I just mean a lot of studies on erythropoietin because of that. And you'll see how amazing it is, because this little innate repair receptor mechanism thing, it only pops up when we have damaged cells, is upregulated. Otherwise, it's not there. And it's almost as if EPO would be a wonder drug, but there's all these other side effects. So it's only reserved for patients with chronic anemia, chronic kidney disease, something like that. Non-hematopoietic analogs of EPO, ARA290. To overcome the hematopoietic and thrombotic effects of EPO, several non-hematopoietic, I would say IRR activating analogs have been developed, such as carbamylated EPO. And that's probably like a fast-acting EPO. I don't know for sure. Apologize for that. But AR290, known as pyroglutamate helix B surface peptide. So it's almost like, okay, we have pyro, fire, gluta, like excited. So it's almost like it's there to put out the fire. That's how I kind of see these things. That's a complicated, something's excited and on fire, and this comes in and it's in the shape of a helix, and it's only 11 amino acids. Targeting the innate repair receptor in neuropathic pain, animal studies. EPO improves neuropathic pain symptoms in a variety of experimental neuropathic pain models. Recombinant human EPO improves sensory nerve function in streptozotocin induced diabetic neuropathy. EPO reduced allodynia and improved motor function in rodents after L5 spinal nerve transection, dorsal root ganglion crush injury, and chronic constriction injury. And I'm kind of going through this fast because this is the part of the study that it gets into just the methods and how they did these experiments on these poor mice. Okay, I mean, it helped diabetic neuropathy. It reduced and improved motor function after an L5 spinal nerve transection, dorsal root ganglion crush injury, and chronic constriction injury. So basically, the mouse could walk again. That's what I'm hearing. That's a big deal. Recently, it has been shown that AR290 inhibits capsaicin-evoked TRPV1 channel activity in dorsal root and trigeminal ganglion cells, relieves capsaicin-induced mechanical allodynia in mice. That's a big deal. I believe that, again, mechanical allodynia would be you just light touch is very painful. Actually, I have a patient who had a severed median nerve during a carpal tunnel surgery, and it left her, like she says, nobody can understand, like, you know, her husband can't even hold her hand on that side because it hurts so much, but you can't see anything. TRPV1 channel, you know, it's just another, it's I believe it's kind of like a calcium channel that is at the more of those the small nerve fibers. So ARA does have some sort of an effect on in addition to the innate repair receptor, it also inhibits these TRPV1 channel probably in the small nerve fibers. So it's got a spinal effect and a periphery effect and a ganglion effect, which means it has an effect on the autonomic nervous system, most likely. This ion channel is a key modulator of neuroinflammation and nociception, and therefore the beneficial effects of innate repair receptor activation likely depends, at least in part, on dampening, like I just said, some peripheral effect, TRPV1 activity of small intraepidermal nerve endings, and on central effects. So there it is. ARA290 effects in small fiber neuropathy. I've got some patients with that. They've got Lyme disease and they've got issues that you would never think. Vulvodynia after laser hair removal, and then they cannot wear jeans for the rest of their life. Why? Because it's a small fiber neuropathy. The administration of ARA290 to humans followed as a logical step, considering the positive effects of the animal experiments. Obviously, pain in sarcoidosis is often related to small fiber neuropathy, which selectively affects thinly myelinated alpha delta or A delta and unmyelinated C nerve fibers. Yeah, I had to review these again because I thought I knew this stuff, but I didn't. Because these small fibers subserve both sensory and autonomic function. Symptoms include neuropathic pain and autonomic dysfunction. And you know, here's the great thing. And I should have said this earlier. I couldn't put everything, you know, in this slide, but in general, you know, people with neuropathic pain, they also have symptoms of anxiety, depression, sleep disturbance, social isolation. I have a patient just like that. And, you know, it's almost like they've got autonomic type symptoms as well. Adrenaline rushes that wake them up at night, chest tightness, pain, even though they have no coronary artery disease, just bad anxiety. But we've got here orthostatic dizziness, dry eyes, facial flushing, incontinence for urine, sexual dysfunction, hypo or hyperhidrosis, and restless leg syndrome, like my one patient I was talking about. I never really understood restless leg syndrome. I just thought it was kind of like for no reason. It didn't make sense to me. But I'm starting to see an association with restless leg syndrome with people who have had back surgeries. The results of the Nervera trial indicate a significant increase in corneal nerve fiber area by 14% within the 4-week treatment period. I mean, that's incredible. if you think, and it caused me, you think dry eyes and dry eye syndrome and all this stuff, and if anything goes on long enough, what if that causes neuroplastic changes centrally? Say if it's dry eyes that worsen over time, and maybe there's neuroplastic changes in the optic nerve that sets you up for that sort of chronic inflammation, hypersensitivity. Then you've got the light sensitivity, for which you've got to wear shades, and your quality of light. I actually have somebody who called me up from New York City who is afraid that he's going to start to have it's a certain stem cell deficiency. I apologize, I can't remember it, but it's a syndrome that eventually the eye just erodes. And I understand his fear, because he cannot drive because the pain is so bad. Well, what if we could regenerate his corneal nerve fibers, and maybe that's what's causing it to be so sensitive, and heal up or modulate the neuroplastic changes or the microglial overactivity in 4 weeks. Functional capacity as evaluated by the 6-minute walk test was reduced by approximately 30% in the sarcoidosis patients with small fiber neuropathy compared with normal age and gender matched controls. So they could walk better, further, approximately 30% more. So they're just overall functional capacity. I don't know exactly what it is, but their overall function improved. After 28 days of ARA 290 administration, 50% of patients receiving ARA 290 could walk at least 25 meters more, compared with only 12% in the placebo-treated patients. The data from one edition randomized controlled trial on ARA 290 have recently become available. There was actually a pharmaceutical company. I wasn't really familiar with it. Maybe it was a smaller, they got all the way up to stage 2, and who knows? I mean, this study is 2016. And I tell you, with all the things that are going on right now, all the autonomic sort of symptoms that people are having, either due to maybe they're getting sensitive to the EMF, okay, the electromagnetic frequencies, because that's going higher and higher and higher. Now we're at 5G. Perhaps some people are getting more sensitive to it or feeling more fatigued. Okay, so it's affecting our nervous systems. Are those people, if that is the case, possible? Okay, not saying it's proven. And then, COVID also affects the nervous system, because there's ACE2 receptors in the nerves and endothelial cells, which are connected to nerves. I don't think there is any endothelial or microvasculature without nerves wrapped around it. And perhaps the fatigue and anxiety and sleep issues, that's all nerve related. Okay. I'm wondering if there's maybe even the vaccine, I'm not saying, but it seems like some of I don't know, there might be something there. Could be. So this would be great. I guess you would think this would be on the market. You think somebody would invest billions of dollars, that it would be worth it, I think, but that's just me. I don't know about that world. Furthermore, an improvement in hemoglobin A1C and lipid profiles during ARA 290 treatment, as well as during the 56-day follow-up, was observed. These data extend the findings in patients with sarcoidosis and indicate that, in addition to a positive effect on the innate repair receptor activation and neuropathic pain, the peptide improves the metabolic profile in patients with type 2 diabetes mellitus, which may have an additional positive effect on the affected small nerve fibers. All right. Conclusion. Selective activation of the innate repair receptor using engineered molecules offers the potential to decrease tissue damage while simultaneously augmenting repair over a wide range of disease processes. The small peptide ARA290, modeled from the three-dimensional structure of EPO, has shown efficacy in preclinical models of disease, including neuropathy, without associated adverse effects. In these models, AR290 has been shown to reprogram a pro-inflammatory, tissue-damaging milieu into one of healing and repair. The favorable effects of ARA290 administration to patients with neuropathic pain, coupled with observed increases in small fiber nerve density as assessed by examination of the cornea, are consistent with disease modification, which is, there is no disease modification, with the other therapies. The other therapies, by the way, I'm reading word for word. Therapies include pharmacotherapy, anticonvulsants, antidepressants, opioids, topical agents such as capsaicin and lidocaine, interventional therapy, spinal cord stimulation, as well as physiotherapy and cognitive interventions with patients often exposed to multiple consecutive treatments. Notably, no disease modification treatment leading to nerve repair have been developed. However, to date, clinical observations have been limited to only 28 days of treatment. Only longer duration clinical trials with extended follow-up will provide critical data with which to assess the full potential of the innate repair receptor. I'm saying it over and over and over for my own practice. Activation as a disease modifying therapy. Here's some pictures, by the way. This is, I didn't want to put the words here because then it would shrink the picture, but this is figure 1, IBA1 immunoreactivity green. So the green part is L5 spinal cord segment of a rat 2 weeks after spared nerve injury of the left hind limb. Activated microglial cells in the dorsal horn and corresponding motor pool are evident on the affected side. So I think this is just showing, hey, you do some sort of transection peripherally, and here's the evidence showing that the microglia have been activated in the spinal cord. All right, so here's this repair receptor. I'm glad we could actually see it instead of me just explaining it. So cells, and I believe it's all tissue, they have these receptors, but they're not expressed. It takes a stress or injury to cause them to come to the surface. And this is the EPO will definitely activate it, but it looks like this looks like just like a little fragment of it, and it does the same thing. And this is that that pyroglutamate. Actually, let me read this before I even say it. Okay, yeah, pyroglutamate helix B surface peptide, otherwise known as ARA290. This little thing right here, boop. And then it activates Janus K2. By the way, what the heck is Jan? Janus is from the Greek god with two heads facing in two different directions and are a gateway. Interesting. So it's a gateway. And January is derived from that as well, by the way. Helps to learn this stuff. Increased tissue repair, decrease inflammation, decrease apoptosis. This is a good. Actually, it's good I have this here. This is showing the reduction in mechanical allodynia after spared nerve injury in the poor rat. There's sham operated, which is blue, and the vehicle gray. You know, those always confuse me. The vehicle is just like if, you know, there's always like a carrier. You know, say something is immersed in a solution. They just want to make sure that the solution wasn't having an effect. So you can see here that that it didn't take much force to produce this mechanical if you just gave them like saline or something. Okay, this would be normal sham. Okay, so it takes a lot of force to get a response, and then you have a real injury, a spared nerve injury, that you either give them the saline or you give them the ARA 290, and you've almost eliminated the mechanical allodynia within 2 weeks, according to this. Okay, so the effect of targeting the innate repair receptor. So this is kind of similar to the first image, where the green indicates the microglial activity. And then you've got, okay, so all of this is the same. Okay, so this is without anything, and this is like going up closer and closer and showing the microglial activity. You see it a little bit more, you know, the green part, you know, or the fluorescent green, I would say, shows the active or the enhanced microglial activity, or there's more microglial activity. Where's the middle one? Is anything by the right or left? Okay, so targeting the innate repair receptor, 2 weeks after spared nerve injury, image in the L5 is indicated by the right high powered magnification. Okay, so I guess this would be 2 weeks after without doing anything, and this is 2 weeks after while doing the innate repair receptor. Let me confirm this really quick, because I remember this being really confusing when I went through this. High power magnifications underwent AD. Okay, and then this shows the vehicle, small nerve and vehicle treatment, BEA. So this is the vehicle treatment. So really there's like saline for 2 weeks. So maybe it got calmed down a little bit in 2 weeks, but not that much, if any. And then you've got the treatment with the innate repair receptor, which is C F and I, treatment with ARA 290, 30 micrograms per kilogram. Boom, you see it already. It's dramatically improved. Okay, so this is I think this is the last slide. Corneal density normal. So I said it's very dense. Reduced corneal density pre-treatment. And this is literally, according to, this is 2 weeks after, 2 weeks after, 4 weeks after. 4 weeks after. I mean, I don't know, guys, this is pretty cool. I'm very curious to hear what people have to say. And I'll try to get off of this screen.
Okay, well, I think it's above my pay grade what you were talking about.
Above your what?
Above my pay grade.
So what do you mean by that? Like,
So the question down here is this stuff available?
well, guess what? This is like, I don't know if this is just one of those coincidences. I literally I was just searching. In fact, I was searching the literature for somebody who has transverse myelitis, which is like multiple sclerosis of the spinal cord. And, I'm just cruising through the data. And then I come across this and I'm like, wow, I've never heard about this. So I look to see where I could find it. And I looked at Can Labs in Canada, just seeing, because, look, if something is safe and somebody has it, I'll try it myself. Okay, I'll try it myself. I think that's very reasonable, because I've had some neurological type symptoms in my neck. I think I've developed EMF sensitivity over the past 2 years, because I've never had this kind of heaviness and tingling and tightness. And it's not because, when things get back to normal, you'll be more active. Oh, baloney. No, this is, I know what I'm talking about here, and I know what EMF sensitivity is, and I know that we're exposed to a lot, and it's working. It's working. In fact, I was getting to the point where I could feel the pain going all the way down my spine, and I was getting concerned because I'm aware that if you have enough inflammation, enough of anything, the longer it goes on, the more you start to develop those neuroplastic changes. And then you've got a polarization, Th17 polarization, which is moving it towards the possibility, depending on my epigenetics, towards autoimmune. And I don't want autoimmune. I don't want multiple sclerosis. I don't want transverse myelitis. And I want to see if I can break that cycle. So I tried it on myself, and I can absolutely tell that I feel more solid. And I've also treated a patient of mine. I have a long-term doctor-patient relationship who is aware it's not FDA approved. It comes from another country. And she said, please, can I try it? Lyme disease, nothing has worked. She's one of those followers of, some of these famous Lyme people. And she's no better than she was 20 years ago. And already she's starting to, her symptoms are more dysautonomia. Well, guess what? This actually just became, and I don't have a relationship with Wells Pharmacy, but I was talking to a patient in Las Vegas who actually said that this was, and I called up Wells, or I talked to them, and apparently this is now out. Either it's available at Wells Pharmacy, or it's soon to be, but I think it's out now. It just came out, of all things. So now I've got this ARA is just gone to the top of my list. I think it's probably the most important thing. And I think it just, and I've gone through other studies on, and then like I said, if you want to, look at put in erythropoietin in PubMed, I mean, you'll see, hundreds and hundreds of studies. It's like, wow, what an advantage to have something like this. So yeah, Wells Pharmacy, of all places, is the first place, I think, in this country to have it. There's another place called Peptide Sciences. I found it at Nevada, and I'm curious if anybody has used their stuff. It makes me nervous when they explicitly say this is not for human and animal use, and they say it's 99% pure. I know they're covering their, themselves legally, but it makes me a little bit nervous. I'm curious if anybody has any experience with trying peptides because it's not available anywhere else, but they're getting it from places that have to say certain things like that. Any feedback?
Well, I think it's under supplements. That's that they are putting it. And yes, Dr. William, you are actually the pioneer of peptides. So this is your plate. And I just want to add something here to make it, even more clear and support Dr. Joseph and his proposal. This peptide is derived from erythropoietin. Everybody knows that erythropoietin is produced by the kidney and it helps to generate red blood cells, but I think they're able to extract certain sequence of amino acids. So it's a derivative of erythropoietin, but its function is to modulate the immune system. So it's immune regulatory, same like thymosin alpha and beta. But erythropoietin works as similar to thymosin beta. So we know that thymosin polarize the immune system to Th2 Tregs. So any disease, any condition that's Th1 dominant, Th17 dominant, then this is what you need to give them. Especially, it seems like it works better for any neurological disease that's Th1, Th17 dominant. I think this is the drug of choice. So multiple sclerosis, and I did send, if you go to the text, general text, you will see which is Th1 dominant, which one is Th2 dominant. So you give this drug for all Th1 dominant conditions, and that includes sarcoidosis, Crohn's disease, multiple sclerosis. Those are Th1 dominant, where you see Th1, interferon gamma, and Th17 overactive. And almost all neurological diseases and injuries, they are Th1 dominant, because any injury, when you have wound or injury, you will have Th1 dominant, Th17, and they will continue preventing the healing. Healing is Th2 Treg dominant. So you have injury and then healing. Injury itself, it triggered the Th1, Th17 cytokines for damaging and destroying any invaders and pathogens. And then after the pathogen has been subsided or it's been cleared, then the healing process kicks in, and then you would have the Th2 dominant, Tregs dominant cytokines, which help the healing process. So this thymosin beta, erythropoietin as well derivative, they are helping to promote the Th2 Tregs effect, healing effect. So you can consider it as anti-inflammatory effect. And yes, we know that all this neuropathy, central pain, drug addiction, all of this leads to abnormal neuroplastic changes in the brain. So erythropoietin does help that to restore it. It helps them complex regional pain syndrome. Yes, it's Th1, Th17 dominant process that needs to be reversed using erythropoietin derived peptides. So it's similar to thymosin beta. So all applications of thymosin beta or low dose naltrexone, which is Dr. Williams' expertise in it, and that helps to polarize the immune system to Th2 Treg, which helps the healing and helps the drug addictions process of which is that they have neuroplastic changes in the pains signaling, and too much of connections there, and needs to be reversed and normalized. Neuropathy, the same thing. You have the substance P and all that activities, which leads to inflammation and triggering neurogliosis. And you want to subside it. You use erythropoietin because it does help to shift the immune system into the healing dominant, which is Th2 Treg. So I think that's something I will definitely consider it intranasal inhalation if you have problem giving it IV, and consider it under the label of supplement. And Dr. William, this is your forte. This is what you do for living. So I think adding this to what you're doing, it's something great.
When you say you're giving this to your patients, is it IV?
Actually, sub-Q is what I've been doing. And as I've read I was not aware of nasal spray. So this is sort of something I've briefly brought it up to Dr. Halassa. So we have not gone further with it. So this is really our time now to really seriously discuss it. But my understanding from other studies, by the way, there's a great study on multiple sclerosis, at least on a rat study that was very favorable. I mean, it's just really exciting. Just immediately, I'm like, it almost seems like, wow, is this real? But it doesn't surprise me at this point. There's a lot of things that, are out there. It's not that are wonderful, that they're just not, they're hiding behind the scenes. But it became evident that if you gave a certain amount subcutaneous, it would be equivalent to if you were to give it IV. And that's how I see subcutaneous. It's a you have to give a little bit more, but that you're giving what would be a reasonable IV dose is equivalent. And I found the dosing to be just like taking any other peptide. There's nothing different than, say, taking thymosin beta 4 or thymosin alpha or BPC 157. Only that I had to order it from Canada. And then today I find out that Wells Pharmacy may have actually just started making it available, which makes me extremely comfortable now. And, again, I try it on myself first. That's my, I do that for my patients to lead, and demonstrate, hey, I had no problems. Based on what I've learned, I don't foresee any problems happening. Yeah. There's studies on epigen, not ep, I always want to say epigen for some reason, erythropoietin, even on alcoholics with alcoholic dementia. So immediately, microglia in our brain, astrocytes, apparently there was evidence that there's modulation there. I think this is pure gold. I really do. And, there's got to be a reason why it stopped at the phase 2 trial, because there's so many things. I wouldn't be surprised if some of these colitises, maybe if they're a Th1 dominant autoimmune, I wouldn't be surprised if it has more to do with if it's more related to neuroplastic changes in the spine at the level of the colon. As an osteopath, we know how those are interrelated and connected, and that the autoimmune, I don't know off the top of my head whether it's ulcerative colitis or Crohn's, but I know one of them is actually Th1 dominant. It makes me wonder if it actually is coming from the neuroplastic changes in the spine. In fact, I know I have a patient who has severe PTSD. He's in the armed forces, or more like a policing, and he also has severe ulcerative colitis. Makes me wonder if there's a connection between his PTSD and his ulcerative colitis. And, now all of a sudden it's not a mystery. It's like, oh, whoever would have thought, it's the spinal cord. Osteopaths, we know this stuff, but we just, we can only do so much through manipulation. But if you can modulate those microglia, stem cell therapy doesn't necessarily cross the blood-brain barrier. This crosses the blood-brain barrier just like that and does its thing. And it's like these results are almost immediate. I mean, we're talking 2 to 4 weeks. That's incredible. But it doesn't surprise me anymore. I feel like most of the time we've just been I'll speak for myself, have been in the dark, thinking, racking my brain, Well, I really do think, I really did not think of neuroplastic changes in the spine being the thing. My patient with restless legs, nothing has worked. I mean, I treated his neuropathy with stem cell therapy, local and IVs. And he got relief from he had terrible neuropathy to the point, like he went to this doctor, that doctor. He was a part of a study at a major university in Raleigh, North Carolina. This guy's a mayor of a small town, and he saw me in 2016, and we did local injections to his legs and feet and an IV, which he requested of me, please, I will try this experimental treatment. I said, okay. And it worked. It was the only thing that helped his neuropathy. But guess what? It did not help his restless legs. His restless legs were so bad that it's like it's getting worse and worse and worse, to the point where he's getting suicidal because he could only sleep a couple of hours before he would wake up, and he'd have to walk it out because and then sometimes it can be in his arms, the restlessness. And he's on 24 milligrams a day of Requip, which is like 3 times the maximum dose. I think I found this as I was searching, and that's the beautiful thing about having real patients as opposed to not having real patients. I don't remember having any patients, by the way, in the first part of my career. I don't even know who any of them are. My patients now, they're sort of counting on me to figure this stuff out for them because nobody else is. And that's how I kind of inch by inch, and and working with Dr. Halasa, I mean, all these things have led to unraveling this stuff right here and other things. This stopped his restless legs in 3. Well, actually, he took a subtherapeutic dose, and then he bumped it up to a therapeutic dose, not even the maximum dose. And at about 3-4 days, his restless legs stopped. And he's actually slept a full night. I mean, I don't like to get overly dramatic in this context, as we have to be objective and scientific about what we do, and we can't, we've got to back up. We've got to be smart with the data and not just, hey, great. And we've got to know exactly why we're doing what we're doing. How is this working? And, what do we do about long-term treatment? But all I can say is that this is extremely promising. Any comments?
Hey, anybody else have any questions, comments?
I'm gonna steal Dr. Joseph from you for my next Monday because I have nobody. So would you be presenting, Dr. Joseph?
Yeah, I'd be more than happy. This is new stuff. I fumbled around, but I feel like I could really deliver this message. And again, there's no, I've got no business relationship with connection to any of this stuff, other than the fact that, hey, I think we've got, even if you have chronic back pain, or even, chronic radicular type pain, neck and shooting pains down an arm, this is a no-brainer. I mean, we have to do all the other things, but, we really haven't had something that targets the central nervous system and affects it so easily and rapidly. There's no injection necessary. You don't have to go to those extremes.
And you can use it for hair growth. So as thymosin beta. So I don't know if Dr. William will be something because he's doing hair growth, right? Are you doing hair growth?
I am, but you can't, if you can find thymosin beta, you're a better person than I am.
Well, Will's Pharmacy, I think they are they're carrying them. I think so. I'm not sure, but yeah, the problem with sourcing, you're right.
So we have some other ways to do hair growth now.
Yeah, Dr. Clearfield, I don't know if this is a conversation we need to have separately, but I am curious, be honest, I'm looking also for cerebral lysin. I used it when it came out, and I did the research. I had a great result on a carpal tunnel, and I know that there's it's hard to find, but there may be some sources, maybe in Eastern Europe, and
I mean,
again,
there's certain outfits that are making it in pill form. Whether it's the real thing or not, who knows? Innovative Peptides, I think, is an outfit. They label it as cerebral lysin and they label it as TB4, but I don't know what's in it. So,
okay, but innovative peptides,
yeah.
is that the place in Eastern Europe, or
No, it's a US based.
Okay. Is there a place in Dr. Steve brings it for his patient? Is there a place in like the Ukraine or Russia? There's a place where, again, it's only for personal use.
We get Cosmo Peptides is from Russia.
I'm on cerebral lysin from William Seeds, but he brings it in himself for his patients directly.
Is Cosmo Peptides, is that something it's findable online, or is this just something that I just
Cosmo, that's not right. Cosmo Nootropics.
So these are more pill form tropics.
Yeah. Mm-hmm. They'll make it into a nose spray also.
Okay, but it's something that I would have to talk to them in order to.
I'm sure. Yeah. Mm-hmm.
And they speak, and it's literally comes from.
A lot of times it'll say, it's coming from Russia, and the shipping, they won't ship it in the summer because it spoils, and there's all sorts of crazy things.
Yeah, I'm just trying to, I just don't want deficits. If there's a place for, okay, we've got peptide, and then there's nerve growth factors, that are a piece of the puzzle for regenerating.
Yeah, we had really good success with cerebral lysin, Salank and CMAX, and can't get them. Nobody's making. I used to get them from TaylorMade, but in Kentucky.
Thank our FDA for that.
If you go on the internet, there's a whole bunch of companies that make it, but if you send them money, you're sending it to China. So who knows what you're getting?
They'll get you one way, they get you another way, right?
The bottles will say not for human. The bottles are stamped
in general.
The bottles are stamped not for human consumption. Also, it says for research purposes only.
Well, now that was the problem I had with the ARA. I'm like, well, this stuff is great, but then there was Peptide Sciences, and they're very explicit saying this is not for human. And then when they say it's 99% pure, I'm like, oh God, I'm. Part of me says, yeah, I know that's probably what they have to say.
That's the reason why that's not for human use, because it's 99% pure. In order for human use, injectable or IV, it has to be 100% pure. Otherwise, it has to be delivered intranasal, topical, as an nutraceutical. That's the reason you can bypass that instead of doing subcutaneous. I think it's better to just do it intranasal.
So just put it in a intranasal spray and just spray it in then.
Right, that's the best option. Or put it with your platelets, nanoparticles, and put it intranasal, because then you don't need the purity. Any injectable, it has to be 100%. That's why they don't label it for human. And the FDA will go after people who are doing injectable for any drug that's impure. It has to be pure 100%. Otherwise, you cannot inject it. But you can do it as cosmetic and nutraceutical and topical or oral. But those peptides, I don't recommend any oral. because they will degrade. The best thing is just intranasal.
Well,
Okay.
Cosmonootropic.com has cerebrolysin, at least on their store. They have it in injectable form.
Yeah, it's injectable form, but if it's impure, then FDA will go after you. So those, just do it intranasal, more peace of mind if you want,
Yeah.
because that's topical. And that's what Dr. Mike Beamer, Amex Pharmacy, they are now entertaining intranasal peptides, but they cannot do injectable.
Yeah,
So that's another way of doing things.
we've used the nasal spray, and we've had some success with that also. So,
And what would be the risk if it's not I mean, are we talking like heavy metal toxicity or just who knows?
I think contamination is probably your biggest risk, and if you cross the plexus and it gets into the brain, that could probably be a problem if it's infected. If it's contaminated.
Yeah. Plugging in my phone here.
So.
This is great, guys. Is there any other, the other thing is I've heard and listening to some of the other lectures, I can appreciate that, open-mindedness and, there are natural things, ayahuasca and things like that were mentioned. And I would love to, maybe if a conversation outside of this with anybody who has, experience, but in the right way, and just learn more about it, for personal pieces, the thing is, I felt fatigued, in a way that I haven't felt before. And, maybe I'm a canary in that respect. So I do all these things. I mean, I've got access. I can give my own IVs if I want to. It's, I've got that skill set. But there's still something that is weighing me down. The neurological part after doing the ARA really made me feel a lot more solid. Okay. I feel more, I even got to the point where I gave myself a shot of Kenalog just to, I'm trying to stay away from that. But, I don't want to have chronic pain that is polarizing my immune system, especially my central nervous system. And I've done some work in San Diego. I've met one of the leading authors for EMF exposure. And I've been, the more I learn, the more I realize, the more I'm awakened to the fact that, we're exposed to, I'm in Chicago. Okay. So, there's the 5G tower right around the corner. And I mean, my ears are ringing, like high-pitched ringing, and I've never had that before. And I'm not going to say, oh, well, it's because I'm older now. That's not a good excuse, because the timing is right when it got turned on. I started having severe ringing and fatigue. And the thing is, as I was sort of making lists, I've got boards in my room where I could just write things down as I think of them, or I channel them, however you want to see it. And, we can buffer the redox, and I love the fact that we can, if you have an innate immune response, well, then we can counterbalance it with the innate repair receptor. I think that's actually a yin yang. But those are still operating at the chemical level. Whereas when we're dealing with EMF, I've got this, this is, now we're getting into the higher levels where apparently, and I'm still trying to learn, this is a pendant that I got. This is from Dr. Plug. I can never remember her name for some reason. Dr. Plug. I spoke to her, hung out with her, and apparently this has harmonic energy embedded into it. Okay, such that and it's been shown that it's causing a grounding effect, sort of like an absorption of harmonic energy, earth grounding, and they've shown with the photos that can detect the photon cloud that's coming off of us. I think it's the far infrared frequency. You know, so you know there's higher levels. There's higher levels, I think, that need to be addressed. You know, we can do all these things, you know, and yoga helps meditate. What's that?
Stay tuned. Next week, we have Dr. Nicholas Ruggiero speaking about his EMF protection products called Presidium. So
yeah. No, I forgot. No, you're right. I actually was the one who got him involved, by the way, not to try to take all the credit, but I've been following him for about 5 years and studying him.
Well, he will be here next Tuesday night.
No, it's fantastic. His stuff, you can't listen to it, you know, just once. He's very deep. But yeah, I do have Presidium, and I'm taking that. So, and my understanding, and Dr. Halasa understands it. He won't say something unless it's really logical and makes sense from which I appreciate. But it seems that it is the Presidium, the probiotic, is EMF, or it's EMF resistant. You know, whether they trained it that way, or whether it's just a certain strain that's resistant that comes from Switzerland. But apparently, that genetic trait, whether it's through microRNA or whatnot, can spread onto the rest of the microbiome, and then onto our bodies, such that the proteins that we produce are sort of buffer. Really, everything's about buffering those EMF rays, and converting it either to a more useful energy or to a less oxidative stress producing energy in the cytoplasm. Now, this is where I'm at with my understanding, and you know, this is a whole nother science, and that's the best way I can explain it right now. But I think that's a big piece of the puzzle. But you know, I really do think we've got to think in terms of, you know, scalar energy. We got to think we're going to have to go a level up higher if we're dealing with electromagnetic frequencies that are almost like shooting darts at us. And I really do think, I hate to say it, but you know, I think it's cruel. Okay. It's real. And anybody who has enough exposure, it grows. It doesn't, you know, and I think I've got it under control. But yeah, most of the people I'm dealing with, and you know how you know, this is how you know, when you have multiple patients, including yourself, having the same complaint at the same time. Okay, that tells me something, because we don't all get, you know, infections at the same time, you know, but we can get hit by frequencies all at the same time. And I'm in tune with this. So, you know, from my standpoint, you know, I like the idea of having, you know, thinking in terms, and, you know, using the data to back it up, you know, and, you know, maybe we'll talk about scalar energies and this grounding technique. And, you know, I'd like to even look up more data on yoga to see, you know, what affects, you know, using that as, you know, any kind of meditative practice that can strengthen our own, you know, production of scalar energy to buffer against this stuff. And then, you know, ARA 290 for the damage that's being done from multiple reasons, to be able to turn on they call it the master switch. by the way. It's a master switch. That tells me something right there, that innate repair receptor is probably the big yang that goes along with the yin to, again, buffer. It's all about buffering, and then ultimately buffering the redox, and then our cellular functions become much more, can't think of the word, but everything's running more fluidly. But there's another word for it, but that's what it is. And that's all I've got, guys. Anything else?
All right. Any questions? Thank you so much, Dr. Joseph.
All right. I hope that wasn't too much.
Brilliant as always. Like I said, it's above my pay scale. I'm sure Dr. Renzo would be able to translate it for me.
Okay.
So like I
All
said,
right.
next week we have Dr. Nicholas Ruggiero is going to be talking about his EMF research and his EMF products. This week I am meeting with an event planner. We're actually expanding. We're going to make our event in Las Vegas truly great. We're partnering with Nevada now has an integrative medical society. They have about 60 members. They're going to be partnering with us, and they're partnered with an Arizona integrative medical society. So it should be really a great event. I'll get some brochures out. We still need speakers. I still have open areas. If you want to see what it's all about, go to our website, aosrd.org, and it'll take you from there. It'll have the event is what we have so far planned. It'll have a registration. We have one vendor already signed up, which is ahead of last year anyway. If anybody, like I said, wants to give a presentation, our four core areas are rheumatology and autoimmunity, hormone replacement, anything cannabis, and practice management. But of course, we'll take, and we also do integrative oncology. And if anybody has anything interesting that they're would like to bring to the table, Dr. Stock, you're more than welcome. We also always put in the 2 hours pain management and 1 hour of suicide prevention, which a lot of the Western states here require for licensing. And I attended AMMG last week, and Dr. Abraham Morgenthaler, those of you who are in the hormone world will know that name. He's a giant, especially in the testosterone world. And he gave such a fabulous talk on ethics that I would like to share it with the group. So there is, I think, once every 4 year ethic, one every 2 years or every 4 years, there's a need for an ethics lecture. We haven't had one. So unless I can find somebody who can do a better job, his talk was just outstanding, and I would like to adapt it for our group. Please try to make plans to attend in Las Vegas, March 25th to 27th. We will be here every Tuesday night at same time, same station, same link. It will be virtual also in Las Vegas, but we would love to see you. It's been a long time since we've been together, and I kind of miss you guys. So with that, any questions, comments, complaints? I see Dr. Stock unmuted himself, so if you have something to say it now.
Well, only to apologize because I was unable to make it because of previous conditions until near the very end of the lecture, and I'm very interested and wondering if this is going to be available on video so I can see all the stuff I missed.
Absolutely. We record everything. It usually takes me 48 to 72 hours to get it up on our website. It's down there again, aosrd.org/webinars. We've been doing this for about a year now, and I'm pretty sure I have at least 90% of them there. And you can get them. You can get the recordings. Sometimes we have the slide decks with it also, but it's definitely there. It will be there. It takes me usually overnight to get it by the time it gets rendered, and I send it to our web person who's in India. And so sometimes she gets to it right away. Sometimes it takes a day or so, but it will be there.
And can you tell me that website again? Because I think I've deleted the email that got me to the thing tonight.
All right, so I put it in the chat box there. It's aosrd.org/webinars.
Got it.
Got it? Okay.
Yeah.
All right. And for the new folks who showed up tonight, thank you so much. Please come back, bring one friend so we can expand our group. Like I said, next week, we're going to have Dr. Marcus Ruggiero. He's going to be telling us all this about some of us who don't know a whole lot about EMFs, and we'll be enlightened there. So, with that, any going once, going twice?
No, I was just going to say one last thing. I think it's great, especially to the ethics lecture. I'd really like to know kind of, I want to, my goal is to do things that are safe, that are reasonable and within, our realm of what we're allowed to do. And, as long as I know, as long as I know what we can talk about, what not to talk about, stay away from, I think it will be great,
Well, as long as the AOA doesn't come down on us, like when you weren't around a couple of years ago when we tried to get Sherry Tenpenny to tell us, give us her views on vaccines, and they told us we not only would they let her have us in the same building, we had to go how far away was it, John? 6 blocks, 8 blocks away.
Jesus Christ.
Yeah.
Jesus Christ.
You remember that in San Diego?
We had a few years of keep your mouth shut and get out of the way. And there are other things we're supposed to keep our mouth shut about now, but we're not doing a good job. We're being discreet. That's all I can say. We're being very discreet.
Yeah,
I gotta tell you, I'm tired of being discreet. I don't know
that's why we
I don't know
brought
what
you.
the Osteopathic Association does to you poor guys. We MDs are pretty much, if we're not taking third-party payment, we're giving the middle of the bird to the damn allopathic medical schools. I just assumed they went off a cliff and died. My medical board in Indiana is not threatening at all, so I say whatever I want. And I swear to God, I say it all the time. I am so sick of this censorship.
That's why we have you here, Dan.
I mean, it's like Indiana's like, we must have the Attorney General from heaven or something who pretty much told our message. In Indiana, your medical licensing board actually can't take action against you. The Attorney General has to be the one who brings the case to the medical board. They can't go after you on their own. So they're like on a leash. And I just look at all the other states and guys, you need to have what we have here. That way you can just tell the system to go get boned.
For what it's worth, I've never had a medical complaint or a patient complaint in 35 years. It wasn't the medical boards that wiped me out. It was the federal courts and some of the other things that are going on within the courts. So they were able to take millions of dollars, totally bankrupt me, and put my wife and kids in the street. Had nothing to do with the medical boards or the organizations I'm with. It has to deal with a bigger picture. So anyway, everything we're doing here is for freedom of speech. We think without freedom of speech, without debate, we're in big trouble. So that's our view.
I can tell you at every single lecture, mostly what I do now is lecture to legislators, trying to get them in the state level to fight off the federal. But I always tell them the solution to misinformation is not censorship, it's debate. Have you ever seen Fauci or Walensky or any of those people ever agree to a debate? I've challenged all of them. I've challenged them to debate Pete McCulloch, who'll hand them their freaking backsides in COVID-19. Those cowards won't come out and do a debate on anybody.
That's why we're here. Thank you.
Okay, thank you.
Thanks for letting me vent, guys. It made me feel
Thank you,
better.
Dr. Joseph, for a great presentation. Thank you, Dr. Stock, for your courage and being that little the church mouse and the wallflower sitting in the corner being quiet. thank everybody who's been here every week. We really appreciate it. We'll be here again, same time, same station, next week. And if you have any questions, problems, complaints, you can get me here at AOSRD. I'll put down my email. It's right there. And I'll even give you my phone. Okay. And so we'll see you all again. Thank everybody for coming. And John, got anything else? Dr.
All's good.
Ortel? No? Everybody good?
Yep.
Okay.
Thanks, guys.
Okay. Thank you.
you.
All right.
Bye-bye.
Thanks, guys.
You.